Today, let's dive deep into Meniere's disease, a complex inner ear disorder that poses significant challenges for both patients and clinicians. This condition is characterized by episodic vertigo, fluctuating hearing loss, and tinnitus. Let's explore the diagnostic criteria and the underlying pathophysiology. Firstly, we need to establish what qualifies as definite versus probable Meniere's disease. According to the diagnostic criteria, definite Meniere's disease requires at least two definitive episodes of vertigo lasting between 20 minutes and 12 hours. Accompanying these episodes, there must be audiometrically documented low to medium frequency sensorineural hearing loss in the affected ear, either during or after an episode of vertigo, along with fluctuating oral symptoms like tinnitus or a sensation of fullness. In contrast, probable Meniere's disease requires at least two episodes of vertigo or dizziness lasting between 20 minutes and 24 hours, coupled with similar fluctuating oral symptoms. When we talk about vertigo, it's important to gauge the severity. The severity scale ranges from mild to extreme attacks. For instance, a mild attack involves brief episodes lasting less than 20 minutes, often accompanied by a vague sense of disequilibrium. Moderate attacks, however, extend up to 60 minutes and significantly affect daily activities. Severe and extreme attacks last longer, often more than an hour, with symptoms like nausea, vomiting, and profound disequilibrium. Looking at the pathophysiology, Meniere's disease is often associated with endolymphatic hydrops, an abnormal accumulation of fluid in the inner ear. This buildup disrupts the normal balance and hearing functions of the inner ear, leading to the symptoms we discussed. Audiometric evaluations are critical in the diagnostic process. In these evaluations, patients with Meniere's disease often show a characteristic low to mid-frequency sensorineural hearing loss pattern, which can fluctuate over time. On the audiograms provided, you can observe this fluctuating hearing loss, particularly in the low frequencies. Management of Meniere's disease can be quite challenging. It often starts with dietary modifications, such as reducing salt intake to manage fluid retention. Medications like diuretics and betahistine are commonly prescribed to help reduce the frequency and severity of vertigo attacks. In refractory cases, more invasive treatments, such as intratympanic injections or even surgical interventions like endolymphatic sac decompression, might be considered. To wrap up, Meniere's disease is a multifaceted disorder requiring a multidisciplinary approach for effective management. Understanding the nuances of its diagnosis and treatment is crucial for providing comprehensive care to affected patients. What are your thoughts on the latest treatment modalities?
Today, we'll be discussing two prominent management strategies for Meniere's disease: intratympanic therapy and selective vestibular neurectomy. Both approaches aim to control vertigo while preserving hearing, but they differ significantly in application and outcomes. Let's break these down and compare the results. In recent years, intratympanic therapy has gained popularity for its minimally invasive approach. This method involves the administration of medications directly into the middle ear, where they can diffuse into the inner ear. The three primary agents used are gentamicin, dexamethasone, and methylprednisolone, each with distinct mechanisms and outcomes. Gentamicin is an aminoglycoside antibiotic with vestibulotoxic effects. It selectively ablates the vestibular hair cells, reducing the frequency and severity of vertigo episodes. However, the risk here lies in its potential ototoxicity, which could lead to permanent hearing loss. Therefore, dosing and frequency are critical to achieving a balance between efficacy and safety. Dexamethasone and methylprednisolone, on the other hand, are corticosteroids. They're used primarily for their anti-inflammatory effects. These agents are thought to reduce endolymphatic hydrops by decreasing inflammation and improving inner ear fluid regulation. Unlike gentamicin, corticosteroids carry a lower risk of hearing loss, but may be less effective in long-term vertigo control. Studies show that gentamicin is more effective in controlling vertigo compared to corticosteroids, especially in refractory cases. However, corticosteroids are preferred for patients where hearing preservation is a priority or where gentamicin's ototoxicity poses a significant risk. The choice often depends on the patient's specific condition and tolerance for potential side effects. Now, let's shift to a more invasive but highly effective procedure, selective vestibular neurectomy. This surgical intervention involves sectioning the vestibular nerve, thereby eliminating the vertigo-generating signals from the affected inner ear. It's typically reserved for patients with severe, debilitating vertigo that hasn't responded to conservative treatments. The procedure boasts a high success rate in vertigo control, often exceeding 90%. Moreover, because it targets the vestibular nerve alone, hearing is usually preserved. However, the surgery carries inherent risks, such as facial nerve damage, cerebrospinal fluid leakage, and postoperative balance issues, which require a comprehensive patient selection process and skilled surgical expertise. In terms of vertigo control, vestibular neurectomy outperforms intratympanic therapy, offering a more definitive solution with less recurrence. However, it comes with greater risks and a longer recovery period. On the flip side, intratympanic therapy, especially with corticosteroids, is less invasive and suitable for patients prioritizing hearing preservation or those unwilling or unable to undergo surgery. In conclusion, the management of Meniere's disease is highly individualized. Intratympanic gentamicin offers strong vertigo control, but at the risk of hearing loss, while corticosteroids provide a safer, but sometimes less effective option. Selective vestibular neurectomy, though invasive, remains a definitive solution for refractory cases. The decision-making process must weigh the benefits and risks, taking into account the patient's lifestyle, severity of symptoms, and hearing preservation priorities.